or a cocaine addict, they had heroin and cocaine to distribute. Not just enough to prevent withdrawal, but to maintain comfort and high.
Yeah,
Okay.
that's not the Amsterdam program. That's the Liverpool program in England, where it's called medicalization program. But it's exactly what you're saying.
All right. Now,
they can go and they can get prescriptions from a doc for whatever they're taking as a way of stabilizing, so they get them out of the life of crime and then start the treatment.
And it was a harm reduction model.
Yes.
And the only requirement was that they had to sign up admitting they had a problem and accept services.
Right.
The question became, or the controversy became, and because it's government controlled, the quality of the drugs were pure and high. So, why would the addict buy from the street? Why would people abuse on the street when they can go down to the clinic and get it free every day, and all they have to do is sign up? And would this not create a saturation and manipulation of the system?
Well, having followed the particular program that you're talking about in Liverpool to see what happened there over a 10-year period, they found marked reduction in HIV rate, first of all. That was the main reason to have this, so that people weren't sharing their own drugs. You could go to the clinic and get it under supervised conditions. The drug overdose rate dropped dramatically because they knew what they were getting. In Seattle and Vancouver right now, we have the highest heroin overdose rates anywhere in North America, partly because of the Asian economy downturn means more pure heroin's coming in at lower prices. People don't know that they're getting twice as strong a dose, and 30 people died just in the last 4 weeks from heroin overdose deaths. Now, if the government were, much as people might say that what's the government doing this for, it's really trying to save lives and so forth, that some governments at least are trying that. The Swiss have instituted heroin maintenance for severe heroin addicts who are unable to stop or unwilling to go to drug-free programs, that they can go to clinics now and get heroin on a basis to maintain their whatever their dose level is, to keep them from going into withdrawal, and then start doing job training and start getting them back in mainstream society, and hopefully they'll, like this guy we're watching the video, like to be eventually drug-free. But it's kind of a midway level. So the question is, if people are going to get heroin anyway, I mean, where are they going to get it from, and how it's marketed, and how it can be used to reduce HIV and overdose rates, is kind of like the question, much as though we might disagree with some of these programs.
So the basic commitment is really, when it comes down to it, that these are lives worth saving.
Yes. Now, some people would say, hey, people with shooting up drugs, they deserve what they get, and why are we trying to help them in any way? But, it's not just the people using their drugs. The highest new cases of HIV infection in this country are coming from IV drug users and their sexual partners. So we can't think of these users just in isolation, they deserve what they get. It's happening, it's a bigger problem than that.
Sure. Or the people who are hit in car accidents or firearms and so forth at Everett's and this.
Yeah.
I'm a little confused, and I'd like you to maybe help us out. You talk about harm reduction as a treatment modality designed to help reduce the harm that a person might be experiencing in their life. But implicit in some of what you've said seems to be a notion that abstinence is the real goal of the treatment, and that harm reduction short of abstinence is insufficient.
Well, I would say because there's a lot of concern that harm reduction is anti-abstinence, I wanted to point out that, in fact, if you look at this continuum model, abstinence is there. It's like part of the continuum. So harm reduction, people would say, if we can get the person to move down this continuum so there's less harms to the person than others, that's good, even though abstinence may not ever be attained. So, I mean, we have to be realistic about it, that not everybody that starts out in a harm reduction program is going to end up abstinent. Some people are going to be on methadone for their whole lives, probably. And others who are able to make differences, say, in their drinking behavior so that they're not causing so many problems, but they're still drinking. That those kinds of outcomes are also considered positive. It's just the range of acceptable outcomes expands a lot more when you have an emphasis on other objectives than just abstinence. But, abstinence is still, I called it a distal goal rather than a proximal goal, because many people that start doing harm reduction right away, that's their proximal goal. Once they've taken a good look at what's going on, and in harm reduction you have to start looking at your behavior and what the consequences are instead of being in denial about it. And then when you get to that point, a lot of people say, my God, I really need to get off this altogether. So they come to that point, but that's not really how they started. So the abstinence there is more of a distal, delayed goal. But it's not that we're trying to get everybody to that goal, it's just that other goals are more acceptable as well.
When the client decides to move on to the abstinence or elects the abstinence as the outcome, that's when the movement is made towards
Yeah, I mean, it's right. Some of them will go that way, and others may not ever attain abstinence, and yet still can make big changes, like some of these folks who are maintained on these medicalization programs in England. Because before, you know, one guy I remember on this video was saying, my life was very chaotic. I was having to steal money every day. I was taking money from my family. I was shooting up in shooting galleries where everybody's passing around needles. And now I go to the clinic and I get my heroin and I can go to work and I have my family and eventually I'd like to do something even more, but this is a great step forward compared to what it was like before. So you always have to think with harm reduction is if you don't do harm reduction, what is going to happen? So you're going to wait for people to hit bottom before they'll eventually wake up to the possibility of treatment? A lot of them are never going to wake up. They're going to be too late already. And so the idea that you could start to work, you know, in the intermediate sorts of levels with people who are just beginning to have problems, like working with adolescents around binge drinking, we're getting very good results with a harm reduction approach because it's something that they can learn, something they're more motivated to do. And even there, some of them will end up choosing not to drink. I mean, how are you ever going to force a goal into somebody, you know, person so that they're going to do exactly what you want? I don't know how, you know, let me know about that when we find out the way.
I found it interesting when you were working with this client that I had a very narrow view of what harm reduction actually was, putting a plan into place and pretty much making it very singular. And as I watched you work with this client, I saw the emerging counseling relationships start happening when the themes of the relationship started coming out. And so what it's expanded for me is that actually it's multi-leveled. It's just not harm reduction, but it's planting the seeds of the relationship itself, the therapeutic relationship.
Yes.
And I think I was missing that as far as my understanding of harm reduction. It seemed much more cut and dry. Let's look at the negative behaviors. And so do you see these clients long enough for a therapeutic relationship to actually
Well, yeah, it's a good
come into
question
play?
because a lot of harm reduction work happens out in the streets because people are not in treatment. They're not coming to your office. They're out there in the alleys or whatever, and you may only have 10 minutes with this person, like if you're an outreach worker. So, but you try and do the same kind of thing, and even in 10 minutes you can have a good relationship with somebody that might make a difference that way. Now, of course, in my private practice, I see people that usually have dual disorder problems. So there's some mental health problem and an ongoing addictive behavior, gambling, alcohol, or something else like that. And what they want is, you know, help on both. And so we can sit together, and obviously the therapeutic alliance is critical to any therapeutic endeavor. But in harm reduction, there's much more emphasis on partnership. That's what I keep saying, rather than authoritarian control type confrontational model. Break through the person's denial system. Make them admit they have a problem. And then, and only then, will we start to help them. It's a very arrogant perspective when you think about it. For many people, that's why so many people with drug problems are not showing up. So we, you know, even in a very short period of time, alliance is critical. And then also, if the person's not doing well, they're in relapse or something, many clients say, well, I wonder if I should even show up again. You know, they're going to really feel, I'm going to feel very ashamed of what's happened. Maybe I'll just drop out. That's where that alliance is critical, because you want to know that your counselor is going to be with you even if you are backsliding, like the guy talked about. You're not going to give up on him, and he's not going to give up on you, hopefully.
So it sounds like that's a major component of even this model.
Definitely.
As in all.
Yes. Now, you don't get a lot of compassion in needle exchange programs in some cases, or even in methadone. because of the fact that, like a lot of methadone programs, you go in and get your methadone, there is no counseling available. And even this guy on the tape said, you know, I would like to have counseling.
Yeah.
And it's true that whenever you have counseling in combination with methadone, or could be nicotine replacement therapies or any of these things, you get way better results. And I'm sure it's because of the relationship with the person that you're working with that's facilitating that. And needle exchange programs, again, like there's one in Seattle, and we brought the guy in who was doing the needle exchange out in front of Tower Records in the University District, where there are a lot of young drug users. We said, you know, what do you do out there exactly? He's got this card table out in front of the record store, and he says, well, of course I exchange needles, but also, he brings out this black book. He says, I got the names of people here where folks who are homeless or are from out of town need a place to stay tonight. I get them set up. I've got numbers of drug counselors here. And he had everything from what you might call harm reduction programs to abstinence-based programs, all available. And he said, you know, for some people that are new in town or whatever, I'm the person they go to when their friend died of an overdose and they need to get the message out to the community. I'm thinking, this guy is a nexus point for providing all kinds of services that these kids otherwise are not going to show up for. Where else are they going to go? So he was very compassionate guy who was a former addict. He doesn't use anymore, but he doesn't sort of force that on people. Yeah. But it's available if you want it.
It has been my observation that this country has moved toward a punishment model right now. And you're raising the harm reduction, it sounds like a paradigm, an emerging paradigm.
Yeah.
And I'm wondering, how much do you think it will be successful in the climate of this country? Because the harm reduction model reminds me of Linda and Mark Sobel, who came just before you in this country and tried something like this, and that's why they are now in Canada, having escaped the sword of those people who are abstinence-oriented. So, this seems to be the full circle for me. How successful do you think the harm reduction paradigm will be in view of this punishment model that is dominating this country for the last 25 years?
By the war on drugs, you mean, that kind of model. By the way, Mark and Linda Sobel are back in the United States at Southeastern Nova University now. They're doing work on studying people who've recovered from alcohol and drug problems on their own without treatment. So they're still actively contributing to the field. Of course, the controlled drinking controversy, which the Sobels were associated with, trying to work with alcoholics to see if they could get them to drink in a safer way, caused huge controversies, especially in the early 80s when there was a lot of publicity about that particular study. And yet now there are lots of places, including where I'm working, where we're offering moderate drinking programs for like college student binge drinkers for whom abstinence is really not, for most of them, going to work. That's been accepted, even though it's, if I'm dealing with a 19-year-old fraternity man and he's drinking like 89% of his comrades in the house, it's illegal. This guy's an illegal drug use. He's not 21 yet. So I could say, hey, you're breaking the law, and we're going to try and work up a punitive approach that would expel people like you for breaking the law and so forth. Or I could say, if you've chosen to drink at this particular age, and you've gotten a DWI already and so forth, you need to come and do something about it. So hopefully we'll get you into a program that where either you could